We've already heard what is spasticity. It is a word derived from Greek, from spastikos, which means to draw or to tug. It's a velocity-dependent increase in the tonic stretch reflexes. It has positive and negative signs, which we typically examine as increased deep tendon reflexes, resistance to passive stretch, and weakness and loss of dexterity. And we've all learned in our first MBBS the spinal reflex arc, and it's a combination and a fine balance between the descending inhibition and the sensory excitation. The modified Ashworth scale between 0 to 4 is used, as is the GMFCS. As my previous speaker has already alluded, the clinical signs that we all look for and what problem the patient comes with, there can be a little bit of a mismatch. Exaggerated deep tendon reflexes are not the patient's problem. That's what we check. Most studies on this topic of spasticity have focused on a single sign and not on the disorder per se in its totality and a holistic look. And as has already been alluded to, the tone may be the one that is making the patient ambulant, and if we reduce the tone, we may convert an ambulant patient with difficulty into a non-ambulant patient. And human spasticity, unlike the animal models, occur few weeks after the insult and not immediately. We've all heard about the non-operative and the pharmacological options, and our chap, the GABA B receptor agonist, is the baclofen. Botox can be a good screening tool if there's a patient with spasticity who responds well to Botox, which, as we all know, is only a temporary solution. It can be a surrogate screening for a ITB therapy. Selective dorsal rhizotomy we've heard, as have we heard about the need for possible soft tissue orthopedic procedures, which should always ideally follow the treatment of spasticity per se. The intrathecal baclofen pump, the common pump, is Medtronic. As the chairperson asked previously, there is alternative. There is a trichomed pump. Unfortunately, that is not a programmable pump. It is a fixed dose pump. The insertion of it is the least of the problem. It's a fairly straightforward operation. There is an abdominal pocket and then a small tunnel, and the catheter is inserted into the thecal space. And the pump itself is a 40 ml pump. Typically, there's also a 20 ml pump, and it sits proud in the abdominal pocket. How does this work? The drug enters the thecal space and through capillary action gets into exactly where we need it to work. That's in the spinal cord. But we have oral baclofen. Why do we need intrathecal baclofen? Especially because it's pretty expensive. The oral has a low blood-brain barrier penetration and high systemic absorption. It goes to everywhere else, not only to the spinal cord. So that is the cause of most of the side effects and the complications of the baclofen. Whereas the intrathecal baclofen directly goes into where we need it to work, and therefore potential for fewer systemic side effects. Whereas a 60 milligram per day oral dose produces only a 0.024 microgram per ml concentration in the lumbar thecal space, the intrathecal injection of 600 microgram per day dose produces a 1.24 microgram concentration. And the concentration is graded for, it's a 4:1 ratio, 4 in the lower and 1 in the cervical region. And that's good because we don't want equal distribution, because the higher it goes into the medulla brainstem, that's where the patient can get side effects like respiratory depression. The pharmacodynamics we are interested in is for the continuous infusion. It takes a little longer to act, 6 to 8 hours, and its maximum effect is observed in a day or two, 24 to 48 hours. Why ITB therapy? Why not do things like selective dorsal rhizotomy, peripheral neurectomies? ITB's main selling point is that it is reversible and potentially fewer systemic side effects. It is also programmable if we choose the Medtronic pump. It is effective in both upper limb and lower limb spasticity, cerebral and spinal origin. Yes, it can be done in post-stroke spasticity as well, and it does not reduce the tone in the normal side. It's a 4-step process where the stage 1 and the stage 4 are more important. The actual stage 3, the implant, is actually fairly straightforward. We choose the right patient. Which is the right patient? It is a patient with spasticity, which is a clinical diagnosis, and we eliminate patients in the very high modified Ashworth scale with fixed deformities, and we also ensure that we don't take in rigidity patients with significant things like dystonia as spasticity. And finally, the maintenance is also important. It is not a single person deciding, the neurosurgeon sitting in his clinic deciding. It's a interdisciplinary team assessment where the patient or the parents and the caregivers also have a role. The goal is that of this therapy is that it improves activities of daily living. In the non-ambulant patient, it helps the caregivers actually clean the patient's private areas. They're able to abduct the hips. It improves hygiene, transfers, catheterization, and things like that. There are very few contraindications, like in a patient with active infection, coagulopathy, or if there is a history of allergy or hypersensitivity to the drug itself. This is the screening protocol that I personally follow. We start with an infusion, with an external infusion pump, and start with a 50 microgram per day dose. Most patients, if they are spasticity, they do respond. In a day, increase it to 75, and then for the third day, increase it to 100 microgram. If they don't improve, then they are not ideal candidates for ITB therapy. For the final implant itself, we start typically with a 50 microgram per day dose in a simple continuous fashion, and at each review that the patient comes, we go up gradually by 20% increments. Side effects are hypotonia, somnolence, nausea, vomiting, headache, dizziness. This is because of the drug getting higher than where you need it. Overdose is rare, and catheter and procedure related complications can occur, and you should be well versed with it. Most common problems are because of dosing errors. We've all entered medicine thinking that we're bad in maths, but here calculation, especially of the drug which comes, and making sure that the ideal concentration goes in and the ideal dosing goes in, we'll have to double check. So ideally, we do it, and a nurse or the technician with us also double checks. Pump malfunctions, programming errors can all happen. And there is something called a catheter access port, which we should ensure that when we are refilling, we use the correct gauge needle and put it only in the refill port and not in the catheter access port. So this is the catheter access port, which can be accessed only by the finer needle and the 24 gauge needle. And the 22 gauge needle is the one that's used for the refill. So this is the next session is the Jugaad tech section, but this is my little Jugaad. We have a refill kit that is generally available, which the company charges for. If you don't have it, we make a impression of the pump and its center, and then mark it, clean it, and then refill. This is how we do the refill. We have to ensure that no air is present in our syringe when we drop the baclofen, and first we remove all the old baclofen and fill it with the new one. So here this is a pump change procedure that we are doing when the old pump has run out. As we heard earlier, it's sort of a gas turbine filled pump, and the gas turbine ends. We remove the old pump and put the new one in. But here, this is the same thing which we do every 6 months or 9 months in the outpatients when the patient comes for the routine refills. Finally, some science. This is evidence is from the early to mid 1990s. It is efficacious in both spasticity of cerebral origin and spinal origin in both adults and children. A picture is worth 1,000 words, a video is probably worth 1,000,000 words. So this is before and after. So this is a gentleman with cervical spondylotic myelopathy who's undergone a fixation, who has residual spasticity, and this is him coming for the first refill about 6 to 9 months after the procedure. Thank you for patient listening.